Good afternoon, everyone. I would like to welcome you to today's webinar entitled Hospitals and the Affordable Care Act, or the ACA. I wanted to remind everyone that today's webinar is being recorded, and the webinar recording will be posted to our center's YouTube page, and that link will be sent out after the webinar recording becomes available. In addition, the presentation slides will be available on the center's website. So before we begin, I would like to mention a few general housekeeping rules. First, if you experience any technical difficulties, you might want to jot down the numbers listed below. This will connect you with GoToMeeting's corporate accounts customer support, and they would be able to help you out with any technical difficulties you may have, including audio. Before I go any further, I want to make sure that everyone is able to hear me appropriately. If you can hear me, could you please click the hand icon, which signifies raising your hand? Thank you. And during this webinar, feel free to submit any questions via the questions box or the chat box. And then at the end of the webinar, we will be taking questions. You will be able to ask those questions either verbally, or we will take them from things that were pre-submitted as well as that were submitted during today's webinar. So let me tell you a little bit about our center. The Hopkins Center for Health Disparity Solutions was founded in 2002 by Dr. Thomas Leviste. We are a research unit in the Department of Health Policy and Management in the Johns Hopkins Bloomberg School of Public Health. Our center has been designated a National Center of Excellence in Health Disparities Research, and we are funded by the National Institutes of Health, National Institutes on Minority Health and Health Disparities. In these very challenging economic times, we are very proud that in fall 2012, our center was funded with our third 5-year grant cycle of funding. Also, too, for those of you who do receive our center's newsletter, I'm very proud to announce that our center director, Dr. Thomas Leviste, was inducted into the Institute of Medicine of the National Academy of Sciences at the end of October. So we'd like to congratulate him as well. And at this time, I would like to turn the presentation over to my colleagues, Andrea Thompson and Michael Thompson. Michael?
Thanks very much. Good afternoon, everyone. And thank you for joining us. My name is Michael Thompson, and I'm going to be leading you through the first half, I should say, of this afternoon's discussion. And then Andrea Thompson will be taking on the remaining portion of the discussion and talking specifically about the gist of the discussion, which involves the impact of the Affordable Care Act on hospitals. Slide. And once more. So we've got these discussion points for you this afternoon. We're going to be defining the Affordable Care Act initially. We're going to describe the main changes that have happened since the Act went into effect. We're going to take a look at how the ACA may affect hospitals and your work as healthcare providers. And then we're going to complete this afternoon's session by answering your questions. So the Affordable Care Act, also known or otherwise known as Obamacare, was signed into law in March of 2010 and later approved in 2012, I should say, by the Supreme Court. Because of the way it was designed, it was designed to be implemented over a 10-year period. Next slide. So what was the purpose of the Act? The purpose was really a threefold design. Number one being able to make health insurance available to more people, to make health insurance more affordable, and then lastly, to ensure that insurance would be easier to understand. If we then look at some of the key activities that have happened to date, we'll be looking specifically at the following. The individual mandate, we'll spend some time talking about the young adult coverage or dependent care coverage. We'll look at pre-existing conditions and lifetime limits as well as Medicaid expansion. And then we'll spend some time talking about the health insurance marketplace, otherwise known as the exchange. One of the most talked about elements of the law is the individual mandate. The mandate stated that everyone had to have insurance beginning in 2014. And there are certain forms of accepted coverage that I've listed here for you. For example, if you have insurance through public sources like Medicaid or Medicare, you're fine and you don't need to do anything. You're also fine if you have coverage at work or have an individual policy, which is a policy that you would purchase on your own, as well as a policy that you would purchase through the marketplace, which we'll be discussing in just a few. Now, if you don't have insurance, you will face a penalty. Next slide. So what is the penalty? It's pretty straightforward. The penalty for 2014 will be $95 or 1% of your income, whichever is greater. Now, this fee increases every year so that by 2016, it will be $695 or 2.5% of your income, again, whichever is greater. And the fees do affect the entire family, and it's capped at 3 times the adult base fee. So, for example, in the year 2014, the maximum for a family would be $285. Next slide. One slide back. Okay. Guess it's not showing up. All right, young adult coverage. This item is probably the most popular of the changes of the law, and what it does is allow parents to carry their children on their policy until age 26. Now, this is despite a variety of conditions that you see listed here. They can be married, they can be living outside of the home, they can even be financially independent, and have coverage at work. So despite all of these elements, as a parent, you'll be able to carry your children up till age 26 on your policy. Next slide. Another key change of the law is the elimination of pre-existing conditions, and I'm sure you've probably heard this one quite a bit in the news. And this is for individuals under 19, and this applies for them today. The change goes into effect for everyone else starting on January 1st of 2014. So at that point, no one will be able to be denied from purchasing insurance despite or having a pre-existing condition. Next slide. Yet another key change is removing of lifetime limits. Before the law went into effect, insurance companies could cap how much they would pay for an individual's expenses over the life of the policy. So if the lifetime limit for an individual's policy was $100,000, that's all the insurance would pay against that policy. So all of your costs after that period would be on you. And for many individuals, that could mean bankruptcy, and in fact did for many. So lifetime limits apply only to essential health benefits, and we'll talk specifically about what those are in just a few minutes. Okay, next slide. So what if you can't afford insurance? Affordability remains a major concern for many seeking insurance, and to help address that concern, the law includes discounts and credits that are available to qualified applicants. So to help with premiums, individuals may qualify for what are called advanced premium tax credits. And to help with out-of-pocket costs, such as deductibles and co-insurance, there are also cost-sharing deductions, which we'll talk about as well. So let's look at one of the main elements of the law, Medicaid expansion. One way that the government thought to provide coverage for a larger number of consumers was to expand Medicaid. And by doing so, the planners believed it would close the coverage gap. This gap existed for individuals who made too much to qualify for Medicaid, yet too little to buy private insurance. However, the Supreme Court ruled that the states had the option to expand or not expand Medicaid in their respective states. Next slide. So if we look at the breakdown of how states have decided upon whether to expand or not expand, it's really a 50-50 or close to a 50-50 spread. And this is changing constantly because other states that did not expand initially have decided that they would and have put in different alternative approaches to the process, which are currently being reviewed. Now, for an illustration of the breakdown, we provided this map for you, where you see the darker blue states have expanded, and that's mainly the western and southwestern states. And then the lighter blue states have not, which are the southeast and south central. And so as we keep in mind that these states, again, that didn't expand Medicaid initially can choose to do so at some time in the future. Now, there are two other changes we want to point to, Medicare and COBRA. So what exactly happens to Medicare as it relates to the Affordable Care Act? And some of you may be wondering that, and Medicare is actually protected. So those covered under Medicare don't need to make any changes. As a result of the ACA, the Medicare beneficiaries will receive free preventive services, which can include mammograms and colonoscopies. They'll also save on brand name drugs, up to 50%, or actually a 50% discount on brand name drugs. And the law will also close the donut hole by 2020. There's also a fair amount of questions related to COBRA. COBRA is the government program that allows you to keep your insurance after you leave a job, but you do bear the responsibility of full costs once that occurs. Under the new law, you have the option of avoiding COBRA and going directly to the marketplace to purchase insurance. And the marketplace will provide multiple plan options and may offer lower costs. All right, so let's spend some time discussing the marketplace. The marketplace, which is sometimes called the exchange, is where individuals and small businesses will be able to go to buy private insurance. So when can you enroll in the marketplace? Actually, open enrollment started on October 1st and will continue through March 31st of 2014. I'll make that, make 2014. Of course, there's a great deal of concern over the federal website, healthcare.gov right now, so that will cause some delays and has caused some delays. However, the enrollment period does go out to March 31st of 2014. Now, after 2014, the open enrollment period changes and will be from October 15th through December 7th, which actually overlaps with the current Medicare open enrollment period. Now, depending on where you live, you have one of three types of marketplaces. The first type is a federally facilitated marketplace where the entire system is run by the federal government, and that's at healthcare.gov. States like New Jersey and Pennsylvania fall under this type of marketplace. Secondly, you have the partnership marketplace, which is run by the state, with some assistance from the federal government, and Delaware's Choose Health would be an example of a partnership. And then there's the state-run marketplace, which is run entirely by the state. Maryland and California would be examples, with Maryland's Health Connection being an example of a state-run exchange. So let's look at the four types of plans that exist within the marketplace. What you have at the beginning is, or actually a set of what they're calling the metal tiers, where you have bronze, silver, gold, and platinum, where the bronze is the plan that requires the most out-of-pocket cost to patients or consumers, I should say, and the platinum plan which is the plan that provides the greatest amount of coverage, also is the one that requires the least amount of out-of-pocket charges for consumers. So each marketplace, regardless of whether it's federal, partnership, or state, will have 4 main health plan levels. There's also a 5th and restricted plan called catastrophic, and we'll talk about that one in just a moment. So what this chart does is basically show you what they're calling the actuarial value, which is a split between what will be paid by the plan and what would be paid by the consumer or the insured. Next slide. So there are a series of essential health benefits that are a part of the marketplace, and these are the 10 categories that these essential health benefits basically make up. If you'll note that the bottom 2 items, mental health and substance abuse disorder services, as well as pediatric services, are 2 services that weren't available prior to the ACA on most plans. Slide. So there are a variety of different preventive services that will actually be free under the Affordable Care Act. And this is just a short list of what some of these preventive services would be. So these services would actually have no copay costs and would exist actually regardless of whether you purchase insurance within the marketplace or outside of the marketplace. Let's discuss the HCPs and hospitals, and this is where Andrea will take over and walk you through some of the details around this.
Thompson. Good afternoon, everyone. This is Andrea Thompson. I have a little bit of a cold, so if you hear me a little foggy, please forgive me. Anyway, I want to take the discussion now into healthcare professionals and, of course, what may happen with hospitals. So let's first start with the healthcare professionals, and this applies to whether you're in a private physician practice or if you're in a healthcare organization like a hospital. So how may hospitals be affected by the ACA, and how will your work change as a healthcare professional? Next slide, Sri. First, let's talk about the HCPs. So there are a number of things that will affect your work. I have them all listed here, and I'm going to take them individually so we can talk about each of them. Next slide. A number of these things have already taken effect. Some began in 2010, others happened in 2011 and 2012, and this year, 2013, there will be additional changes coming 2014 and beyond, such as free preventive care. All new plans must cover certain preventive care services such as colonoscopies and mammograms. In the past, individuals may have given a copay or had a deductible. That's no longer the case. There's free preventive care. Rebuilding the primary care workforce. There are new incentives now in the law to expand the number of primary care doctors, nurses, and physician assistants offered in different loan programs and grant programs to incent individuals to move into the medical profession and become primary care physicians or nurses and so forth. There's the expansion of Medicaid. Michael has already discussed that some states will expand and receive federal funds. Other states, some are still on the fence as to whether they want to expand or not, and others have decided that they will not expand. Regarding rural health providers, this has always been an issue. Well, now the law will provide increased payments to rural healthcare providers to help them continue to serve their communities and actually to incent new healthcare providers to go into rural communities and begin to service those communities. Next slide. Strengthening the community health centers. The law has provided a lot of money actually to continue to support and expand, to support existing and expand new healthcare centers across the country. Those monies have already begun to flow, so you may have already seen some of this within your community. Improving healthcare quality and efficiency. You'll hear me talk a bit more when we talk specifically about what's happening in the hospital. The law establishes a new Center for Medicare and Medicaid Innovation. They are testing all sorts of new ways to deliver care to patients, and they put out requests for proposals to businesses, individuals, for-profit and non-profit organizations to come forward with projects that offer new ways of delivering care. So we're looking forward to what those kinds of projects may produce. They're all aimed to improve quality and reduce cost, and hoping to target a lot of waste in the system, thereby reducing costs as well. So like I said, a lot of the projects are targeted towards reducing waste. Of course, reducing paperwork and administrative costs. This has been happening a while. There's this push to go to electronic health records, not only for quality reasons, but certainly for better communication as well between healthcare professionals. Next slide. Reducing health disparity. This has been an item of discussion for some time now. The law requires federal health programs to collect, report racial, ethnic, and language data. Some organizations have already been doing that. This is totally new for other organizations. Increasing Medicaid payments for primary care. The law requires states to pay primary care physicians no less than the current Medicare rate. So that is something to look forward to for those individuals who've been working specifically in Medicaid environments. Ensuring coverage for individuals participating in clinical trials. That's kind of self-explanatory. If you've been in a clinical trial, especially those trials that treat cancer and other life-threatening diseases, insurers cannot limit or drop your coverage. That's important. Paying physicians based on value, not volume. You've heard a lot about this. Payments are now tied to the quality of care. Next slide. And now let's just talk about some of the things that may affect hospitals. Next slide. Well, one of the first concerns is certainly the surge of patients. There are 32 million uninsured individuals in the United States, and many of these individuals will come into the system for the first time. These are people who have never had insurance. So the increased number of newly insured, the expansion of Medicaid in the states, this could flood hospitals with new patients, and these could be patients who are sick individuals. So that's what we mean by high use, and that will tax the already understaffed teams within your healthcare institutions. Hospitals may also receive less money for the same services that they've been given based on the government's decision to lower Medicare reimbursements. So that certainly could affect your institutions financially. Next slide. More transparency is required from hospitals. The Affordable Care Act aims to increase transparency by requiring tax-exempt hospitals to conduct a community health needs assessment. That has to be done regularly, and there will be a penalty if it's not done. These hospitals will also be required to establish a written financial assistance policy. More demands on these hospitals. Next slide. This program has already started. Transitional care for seniors leaving the hospital. Those of you who work in healthcare organizations know that readmissions and sometimes unnecessary readmissions is a really big problem. So the Community Care Transitions Program will help Medicare beneficiaries when they leave the hospital to help them avoid unnecessary readmissions by coordinating care and keeping those individuals out of the hospital. Thank you. Next slide. Quality-focused service. There's less volume, more quality. That's going to be the norm among hospitals. You're hearing a number of buzzwords out there, or buzz phrases. There will be expansion of accountable care organizations. The law is providing incentives for physicians to join accountable care organizations. If these accountable care organizations provide high quality and reduce costs, they will be able to keep some of the money that they help save. Hospitals will be a part of these accountable care organizations. Everything will be focused on quality, not quantity. Next slide. Like I said, let's continue. Linking the payment to outcomes. Hospital performance is required to be reported publicly now. And during this transition towards quality, hospitals will operate in two different worlds, part volume and part goal-based performance. Financial incentives are available to hospitals that perform well. And the government is going to determine what good performance looks like. They will do this through a combination of clinical outcomes and patient satisfaction surveys. Next slide. There are two payment systems that are being established with the goal of tying reimbursement to quality, and they are value-based purchasing and bundled payments. I am certain if you're in healthcare organizations, you've probably heard of these two systems already. The government will be penalizing hospitals that perform poorly, and those hospitals who have excessive readmission rates will receive lower Medicare reimbursements. I just talked about that community health program. That's one of the programs that's been put in place to help hospitals lower readmissions. And if you don't do that, those hospitals with excessive readmission rates are going to receive lower Medicare reimbursements. That's, again, another financial effect. Should the act help more people get insurance? Hospitals could get paid for charity care that they now provide for free to uninsured patients. So many of you are going to continue to see uninsured patients, and some of those folks will have insurance. Some can have insurance but have not taken the time to get insurance. So you're going to continue to see that happen within your organizations. Next slide. This law is complex and will be challenging, and one of the major concerns is there's going to be a lot of churn in the system. So healthcare professionals have to be aware of what has already changed from 2010 forward and what changes are continuing as we move forward. So I just want to give a quick example of some of the situations you may encounter. It's just an example of a family and an example of the churn that will be in the system. Next slide. So the example is about split eligibility, and I'll describe for you a family. We've got a pregnant mother, her 5-year-old child, her husband, and they have a household income which is about 150% of the federal poverty level. So while the mother is pregnant, she qualifies for Medicaid until 60 days postpartum, until she has the child. And then she transitions to the premium tax credit program. The father right now is on the premium tax program. The newborn, when the newborn comes, will qualify for Medicaid until they're age 1, and then they'll transition to the CHIP program, the Children's Health Insurance Program. The 5-year-old is in CHIP. Next slide. So the eligibility rules are confusing and highly complex. So different family members may qualify for different public programs. And these family members could be split across insurers and delivery systems. Next slide. So you could actually have a family come in with all different insurance cards and be in different programs. This is something you've got to pay attention to, especially the individuals who are responsible for billing and coordinating care. That this type of churn and these types of scenarios will exist in the system and could drive people mad if they're not watching and not understanding insurance and how quickly these things can change within a family. Because as a family changes income, if someone is, loses their job or whatever, this could all shift again. So this is what we mean by churn in the system and complexity that's coming into the system. Next slide. So we have a few recommendations. Educate, educate, educate. You've got to train your staff the basics of the Affordable Care Act, and they really do need to understand health insurance. Health insurance has a language of its own, and you would benefit from training your staff health insurance. Things have changed, so our recommendation is certainly to begin to talk to your staff about what the changes are and let people ask questions. You've got to begin to educate on what's changed in the law and what's changing about insurance. Prepare yourself for a high probability of churn. Again, you have individuals coming into your organizations who have never had insurance before, so they're not going to know how to use it. You've already got issues with people knowing how to navigate the healthcare system. Add that on top of not understanding how to use insurance. So you may want to develop a cheat sheet for yourselves and for the individuals who are, especially those individuals who have to deal with the public. Next slide. So let's go over some points to remember. The marketplace is the new way to find and buy health insurance. We all know that now. Individuals and families may be eligible for lower costs on their monthly premiums and their out-of-pocket costs. Newly insured individuals will require special attention and different systems. And that's what I've been talking about thus far. Next slide. Other points, insurance will continue to be sold outside of the marketplace. So the marketplace is not the only place to get insurance. Purchase from the marketplace is not required. But the marketplace is the only place to get tax credits and cost-sharing reductions for purchasing insurance. Healthcare professionals and healthcare organizations can expect churn. If you've got nothing else from what I've said today, we will have some churn and chaos in the system. Educating your staff is critical. Next slide. The system is changing to pay for performance. We talked about quality versus quantity. You're going to hear more and more of that as we move forward. Accountability and efficiency are the words of the day. Accountable care organizations may be a viable option for some hospitals, not for every hospital. We do believe that a lot of hospitals will survive this, but quite honestly, many hospitals may not survive this. And the last point, of course, is about cultural competence and linguistically appropriate services. It's important that you prepare your environments for whomever your customers will be. And that's going to require that your staff, from the administrators to the people who are serving in your cafeterias, they need to have some level of cultural competence, and your healthcare environments have to have linguistically appropriate services to service the individuals who will be coming to your halls and talking with your staff members and expecting service from your organization. Next slide. So let's move to some questions, Cherie.
Hi, thank you, Andrea. Thank you, Andrea and Michael. I appreciate that presentation. And I'm going to make sure all three of us are unmuted. Let's see. Okay, great. So we're going to go ahead and take questions. And we received some questions in advance. And as I had mentioned, you can go ahead and type your questions that you may have. Taking questions, I want to ask those in attendance a question. So if a patient came up to you today and said, I don't have insurance, I've heard something about the Affordable Care Act or Obamacare, would you know where to send that patient for assistance? So by a quick show of hands, would you know where to send that patient? Okay, so I'm looking, I'd say not quite 50%. So what's going to be really crucial, and this is something that both Andrea and Michael mentioned, is that depending on where you are located, what states, you can have insurance offered via one of three different manners. So it could be the healthcare.gov, it could be the state partnership with the federal government, or it could be a completely state-run exchange. So you need to find out specifically what kind of exchange do you have in your state, and you also need to let your patients know that whatever that website is, whether it's healthcare.gov or a state-based website, such as here in Maryland, it's Maryland Health Connection. If you're in Illinois, it's Get Covered Illinois, and a whole host of other ones. You need to know where to send your patients, and also that it's the one-stop shop for all kinds of insurance, which Andrea and Michael mentioned, whether it's public insurance, meaning Medicaid, and in some instances Medicare, but also for private health insurance plans. And as they mentioned, consumers and patients can purchase insurance outside of the marketplace, but the tax credits that they would be eligible for, they can only use those if they purchase through the marketplace, either for the federal government or their state. So that's really crucial. So when Andrea mentioned creating cheat sheets, it would be very helpful to have this information as your patients are coming to the various points of entry in your hospital, or if you're a healthcare provider. Would you agree with that, Andrea and Michael?
Absolutely.
Okay.
That's
Great.
where we think the greatest amount of, Cherie, I just wanted to mention, that's where we think the greatest amount of confusion is going to come about, and that is, where do you send patients who come in with all the questions that they may have?
Right. I agree. Absolutely. And because I work mainly with hospitals, I've been talking to colleagues around the country, and I was talking about the Affordable Care Act. Many people did not know the basic principles of the Affordable Care Act. In fact, quick show of hands, how many people had seen the Jimmy Kimmel episode where he had one of his reporters go out on the street and ask people which one they preferred, Obamacare or the Affordable Care Act? Quick show of hands. And if you haven't seen it, you've actually heard of it. So again, we're not quite 50-50. So this was a case of where they went out and asked people, so which one do you prefer, Obamacare or the Affordable Care Act? And the majority of the people did not realize that they were one and the same thing. So it was just very interesting to hear how they rationalized this. So if you're going to be going out and doing trainings in your own institution, just Google, I think it's just Jimmy Kimmel, ACA versus Obamacare or something like that. And that would be something really useful to use in your trainings. So thank you for those who raised your hands. So we have several questions coming in, and we have several questions that were submitted in advance. So I'm going to start with the first question. And this question is, if safety net systems also treat undocumented patients, how will they survive without disproportionate shared funding?
Michael?
Michael, would you like to address that one?
Can you hear me?
Yes, we can. Thank you.
Yes. With respect to the, excuse me, I'm having some difficulty with my headset here. Can you hear me now?
Yes.
Sorry. The truth is that some safety net hospitals may not survive. Quite frankly, the ones that will be the ones that have some creative efforts to coordinate care with other providers, as well as the ones who will be reevaluating, I should say, their cost structure to look at the removal of waste and inefficiencies in the system. So it's a real problem, and I think without the help of some specialists looking at the details of the cost structure within these organizations who have been who've had their funding cut way back, it's not likely that a majority of them actually will survive.
And for anyone who's online who doesn't understand what a safety net hospital is, we're talking about an organization that provides care to low-income, uninsured, or vulnerable populations. They are oftentimes referred to as safety net hospitals.
Right. Thank you for that clarification. So in addition to that, we have another question, and this question is, what will happen to individuals in long lines for care at public hospitals? Can we help them transition? Andrea, would you like to take that one?
Yes. This is one of the things we've been talking about. When I mentioned education, if you don't, if your staff members don't understand the basics of the Act, if they don't understand insurance, they will not be able to help individuals who are coming into your organizations. You're going to find that you not only have long lines, but total chaos, because a number of these individuals do not understand how to use insurance. And on top of that, there are major health literacy issues as well as health insurance literacy issues. We both know that healthcare has its own language, health insurance has its own language, so you will have people who don't understand how to coordinate or navigate a hospital or the healthcare system or insurance. So I think there's going to be a number of long lines and certainly some levels of frustration. And that's why we're talking about these things now and asking you to begin to educate yourselves and your staff and put things in place so that you can cut down on this as much as possible.
Great. Thank you, Andrea. Another question we have, and you addressed this a bit when you were talking about how certain hospitals may not survive these changes. How may efforts by safety net hospitals to participate in accountable care organizations affect the viability of these hospitals?
Michael, do you want to talk more about the safety net hospitals?
Yeah.
Yeah.
Go ahead.
In terms of how the safety net hospitals will be affected by this whole process, first of all, Andrea talked about the whole purpose behind accountable care organizations and the fact that it's really a series of different providers who are coming together to focus on quality goals. A lot of the safety net hospitals just simply won't have the resources to devote to these efforts, again, because the funding is continually being cut back. And safety net organizations face many of the same challenges that other organizations attempting to provide accountable care face. They include, the amount of risk that they assume, the degree to which they are trying to provide coordinated care across multiple areas, as well as how they collect, analyze, and report data. So they have a number of additional challenges associated with providing those resources while not having the necessary funds to do so.
Yeah, if you think about it, a number of safety net hospitals have not even been able to accomplish getting everything into electronic medical records. I mean, resources are a major challenge, and because of the kind of organizations that they are in providing free care, everything within the organizations, gets to be a little bit challenging when finances are an issue. So, like we said earlier, we think some safety net hospitals may be able to participate, but quite honestly, if we're honest with ourselves, there may be some hospitals who don't survive this at all.
I see. Thank you for that. So we had a couple of questions come in, and I also see a hand raised. So let me go to the person first who has a hand raised. Elisa Walker, I'm going to unmute you so that perhaps you can ask your question. Elisa? Okay. If you're not able to speak and you would like to ask a question, you can go ahead and type it in, and then I will take your question that way. I see we have another hand up, and this is from Lindsay Hill. Lindsay, I'm going to unmute you. Hi, Lindsay. Can you hear us? Lindsay? Okay. In order to speak using your telephone, you would need to enter in the audio pin that popped up when you clicked telephone. Lindsay, are you able to speak? Okay, I'm going to mute you, and I'm going to go to the other questions that have come in. So we have a question from Brenda Snipes. And Brenda has a good question, and that question is, where can employers get accurate information to use for staff training? So either one of you, Andrea or Michael, if you would like to address this, and then I'll add something afterwards.
Yeah.
Go ahead. I think there's a couple different places that you can get accurate information. One place is the designated broker or agent who's working with your organization. There's some great information available through healthcare.gov that walks through a lot of the details. And the Kaiser Foundation also has a variety of information that's available, as well as organizations like ours who provide a variety of different training in that area.
Yeah, I was going to add also about the Kaiser Family Foundation. Their website has lots of great information that can be used for training, including videos. And there are videos now on YouTube that might be, good training videos as well. But as Michael said, there are organizations like ours out there who can also help hospitals or private physician offices, for that matter, get some training in place.
Great. Thank you, Michael and Andrea. And I wanted to add, so Andrea, you mentioned Kaiser Family Foundation. They're a great resource. You're a great resource. Both in English and Spanish, it's called U-Tunes, Y-O-U Tunes. So if you just Google U-Tunes, there's one in English and Los U-Tunes in Espanol and Spanish. And so it's a very simplified way of explaining a lot of this complex information that we just have. Excuse me. Another thing I would highly suggest, and I just, again, want to get a quick show of hands here. How many of you have heard of navigators and or assisters? Okay, I see about not quite half. So, of those of you who have heard of navigators and or assisters, is your hospital or is your healthcare organization working with them? Because these are the people who were either funded by CMS, excuse me, if they were working in a federal marketplace or a federal and joint state marketplace, or if it's a state, the state funded these various areas. So I'll give you an example. Here in Maryland, we have the Maryland Health Connection. The state of Maryland was divided into various regions. So there are health connector entities, and they are responsible for providing navigators as well as assisters whose jobs are to actually go out into the community to educate, to inform, and actually to help people navigate both the healthcare.gov and the Maryland Health Connection websites. So I would highly suggest that you partner with those organizations and find out, because in cities there are people who have been charged with doing this, as well as in your state there are multiple entities. So I'd highly recommend that you partner with those as well.
And there are the government websites, Cherie, like healthcare.gov. They even have slide sets that you know, can be used. The government information can be used freely. There is no charge for that information out there. So they do even have slide sets that you can pull on.
Right, absolutely. That's a good point, Andrea. In addition to having slides, there are fact sheets that are 1 to 2 pages that are very simplified. There are glossaries. So, Andrea, to your points about health literacy, helping consumers to understand what is a copay versus a deductible versus co-insurance, because as you said, many of these people have never ever had health insurance before. And even for those of us who have had health insurance for many years, it can be very difficult to navigate the system and know what these items are.
Yeah, so my recommendation is certainly when you begin to look at training, and I've been through, Mike and I have been through a lot of the government resources. A lot of their training material is not in what we call plain language. So
right,
just because you see the government info out there, you need to go through it yourself and determine, okay, is this clear? Because what we had to do is go through many of them and break it into plain language or language that people use more conversationally so that they understood some of these terms. Those of us who have had insurance our entire lives don't understand some of what health insurance is all about and some of the terms that they use. So Mike and I have spent the past probably year talking to people and breaking down health insurance and simplifying it as best we could to have people who've used it for years understand it.
Right. That's an excellent point. Thank you for clarifying that. In addition to, our center has a page that we put together. It's not all inclusive, but it's kind of a start for, again, some of the sites that we've already mentioned, healthcare.gov, Kaiser Family Foundation, Commonwealth Fund, etc. And it has general resources. It has resources for the Latino Hispanic community. It has LGBT resources, and I'm going to put a plug in. We are holding a webinar on Thursday with the Center for American Progress, Kellen Baker, and it's on Out to Enroll, which is basically a navigator program to help the LGBT community also gain access to health insurance. And so that will be the same time as this one, 3 to 4:30. I can also send that information out to everyone who registered. So that's another way, because if you have LGBT people in your community, that's another way to reach them as well and giving them the information they need. And along with that, I see we've had a couple of questions asking, I think if people joined after the first 5 minutes of the webinar is being recorded. The slides will be made available, and we will be sending that out to everyone within 24 hours of today's webinar. Our webinars are always recorded and placed on the center's YouTube sites, or YouTube channel, I should say. So if you ever go to YouTube and you type in the center's initials, HCHDS, then all of our webinars are up there as well, and they can be shared. So let me look at some of the other questions that have come in. So from Alan Noonan, we have a question, and it is, how will public health...
Cherie?
Yes.
I didn't hear that question.
I'll repeat the question, yes, because I heard a background noise. This is from Alan Noonan. How will public health systems and expertise be used to help hospitals with their new community health responsibilities?
I'm not really sure what they mean by that.
So, Andrea, I'm going to take a attempt at this one, and Dr. Noonan, if this isn't what you were getting at, if you wouldn't mind typing back in a point of clarification. So I was wondering if you were getting at perhaps the use of community health workers assisting hospitals or promotores, and actually going out into the communities and using community-based, maybe faith-based initiatives to assist the consumers and the hospitals with these new responsibilities. Is that what you meant? And if not, if you wouldn't mind typing a clarification, please. Okay, yes. Thank you. Thank you for that clarification. Yes, he did say correct. So yes. So hopefully people are aware of community health workers and promotores for the Spanish-speaking and Latino Hispanic community. And some healthcare organizations have been using them to partner with them. So, for example, Andrea, when you were talking about the whole avoidable readmissions and the Medicare transition program, some organizations are using nurses and pharmacists and case managers. Other ones are using community health workers to do home visits, to make follow-up phone calls, to actually do group counseling and group-based visits to help prevent those avoidable readmissions. And we're also doing this, chronic disease management, whether we're talking diabetes, hypertension, a whole host of other things, obesity, etc. So, yes. So I think
there are also some nonprofit groups within some communities who are taking this on as well to try to help educate their community, especially people who might have, I know we've got an organization in Trenton, New Jersey, Children's Futures. They've been talking with us about helping them to set up some type of communication for individuals within their community who can come in and perhaps sit and talk to somebody and get some help about this whole change in healthcare and what they need to do to get insurance and just answer their questions.
Right, and that's an excellent point, because that has been, we've had these conversations, and one of my big concerns is it's simply not enough to place information on a website or to post an 800 number, whether it's on the side of a bus, on a billboard, or in a pamphlet. We really, really need to be going to where the uninsured populations are. And to your point about community organizations hosting forums and educating people in their communities, I participated here in my county 2 weekends ago. The NAACP in my county organized a forum on the Affordable Care Act, and I was one of the speakers. They brought in the navigators and assisters from our county. We answered people's questions, but one poignant question, which again is one of my concerns, the person asked, how many people are uninsured in our county? And our number was 20,000. The person's next question was, do we know who those 20,000 people are? And if so, why are we not specifically targeting those individuals rather than generically targeting and hoping people will come?
That's a very good point. And the government does have the data by state, actually, on and by county, I think, on how many individuals within those areas are uninsured, and they even have it by gender and by income level. So I think using the census information from 2010, they were able to break down a lot of this information. So that data is out there.
Right. And also, too, Dr. Noonan, this is an excellent point. So when we were talking about both community-based organizations, it's also talking about the expertise that lies in the local and state health departments. So that's actually the model that has been used in many states, where the navigators and assisters in many cases are housed in local health departments. or community action agencies, etc. So I agree, that's an excellent point as well, and partnering with those organizations. Let's see, so we have a few more questions that came in, just scrolling through here to look. Okay, yes, we do have people who agree with us that the materials that have been, not your materials, but materials that have been presented in general haven't been in a user-friendly, understandable manner by any means. Because as we know, like there is legalese, like there is medical terminology and jargon, even with health insurance and with those. And the website information, this is healthcare.gov is the main point. And when you go to healthcare.gov, if you click on your state, it will tell you, for example, if you clicked on Maryland, because that's where I happen to be, it would tell you, oh, Maryland has a state-based exchange, go to Maryland Health Connection instead. Versus if you clicked on some other states, it would say, no, you actually would go through healthcare.gov. And as I mentioned, when you do receive the email that shows you the link to the webinar recording as well as to the slides, I will also provide a link to, again, Andrea and Michael's website, as well as the Affordable Care Act website that our center has kind of put together that's trying to be a repository of resources. Because there's information coming out daily. In fact, multiple emails coming out daily about the Affordable Care Act. Uptake, whether it's issues with healthcare.gov and the rollout, etc. So I see a couple of other hands. Let me see if I can try to take some questions that way. Okay, so let me see. Celeste, I see you have a hand up. I'm not sure if that was related to one of the poll questions I asked, but I will try to unmute you. And if you don't want to ask a question, I believe that there's the ability to click a button so you can put your hand down. Okay. So let's see. Matthew, I see you. Matthew Rice, I see you have a hand up. I'm going to unmute. No, let's see. I'm going to unmute to see if you have a question. Hi, Matthew. Did you have a question?
Sorry, my hand is down. I do not have a question.
Did not. Okay, but we have someone whose audio works, so that's good to know, too. Thank you, Matthew. Appreciate that. And I see Elisa had her hand up, but I think we had asked her question, answered her question. Dr. Ann Barnes, I see your hand is up. Let me see if Dr. Barnes has a question. Dr. Barnes, do you have a question? Yes, okay, I see your question just came through. Give me 1 second, please. Oh, okay, no problem. Thanks for the confirmation. So I am going to, let's see, put all hands down. I'm mindful of our time. We actually have until 4:30, so this is your opportunity, really, to ask any question you might have about the Affordable Care Act, whether it's myths, things you've heard, clarification. So use this time. I mean, we're here, and this is one thing that Andrea, Michael, and I wanted to do. So, okay, I see Kim Allen has a hand raised. Let's see. I'm trying to unmute you. Oh, no, I think Kim put her hand down. And then let me see if Elisa has another question. Okay, if you have any other questions, feel free to go ahead and submit them, please. Okay, good. I do see some more. So this is from Ken Hemley, and the question is, what is the difference between navigators and CACs? Do you know if volunteers are being used? So this be the certified assistant counselors?
Right.
Certified assistance counselors? Yes.
Right. The navigators are actually the individuals who have received training, more training to assist individuals. The CACs are volunteers. They absolutely are not getting the amount of training that the navigators are required to get, so they may not be able to answer all the questions that navigators are supposed to be able to answer. However, my experience with navigators, especially here in the state of New Jersey, some of them are not getting the proper training either, because in the state of New Jersey, we only had just over $1 million in funds provided for training for the entire state. So a lot of the organizations who took on this responsibility of navigators, they couldn't pay anybody to do it, so they actually had to solicit volunteers to be navigators. And those individuals, many of them are retired seniors who did go ahead and take the required training, but they can't answer a lot of the really tough questions about health insurance or about the Affordable Care Act. So unfortunately, a lot of these individuals don't know what they don't know. But to your question, is there a difference between the two? Yes, there is. The navigators are supposed to be the better educated individuals about this. Michael, do you want to add something?
No, I think that you touched on what's key about that is that the navigators have more knowledge and have gotten greater input both at the national level and at the regional level, whereas the certified assistants are basically there just to kind of answer some of the more basic questions.
Great, thank you. We have a question from Tim Allen, and I don't know if we'll be able to answer this specifically, but we can look this up and get back to you on it. But one of the questions is, how does the ACA impact autism habilitation coverage? Meaning, for example,
I don't have an answer for that.
And what I believe that is basically if your child requires speech-language pathology or behavioral health therapy, yeah, or different therapies out there, would that be covered perhaps under the essential benefits that must be covered? And let me just ask, Kim, is that what you were getting at? So, Kim, I actually have several friends who have children with autism, and we've been having this discussion. I have your contact information. We can look up that information for you, and I'll contact you offline, because it might be based specifically based upon the kind of what state you're in, what services are being offered, et cetera. But we will follow up with you on that question, because that's a little bit more of a deeper dive than we'd be able to respond to during today's webinar. But your other question, which is, oh, I'm sorry, this is Kim Allen also, is does the Affordable Care Act include expanded mental health coverage for peer-certified mental health professionals? So, Andrea or Michael, did you want to take that one? I mean, I know generally about mental health services being an essential benefit, and there's supposed to be parity with medical care services. However, beyond that,
right, and I think that is an area that is still being defined. Keep in mind that a lot of this stuff is still very fluid, and they're still trying to determine exactly what some of these coverages will be. Right now, it's very general and broad because, you know, we're just getting started here, and they've not been hit with a lot of this stuff. So we don't have, you know, specific answers, and any specific answer we give today about something like that could change tomorrow, because many of these situations are quite fluid.
Okay, great. Thank you. So I see we have several other questions. So one of the questions was, I had mentioned our YouTube channel. So when you go to YouTube, that is www.youtube.com. And if you type in the center's initials, which are HCHDS, which stands for Hopkins Center for Health Disparity Solutions, you would then have access to all of our previous webinars on a host of different topics. And then, let's see, we have several other questions. This is from Elisa Walker, and thank you, Elisa. She said that at their hospital in Iowa, they have about 13 certified assistant counselors. They have 2 Medicaid specialists. Herself and Brenda Lewis were trained also as navigators. And so they found it very helpful to have the additional information. So thank you for that feedback. And then also, too, Elisa mentioned that their assisters actually happen to be paid staff. And I think, Andrea, Michael, the model varies from state to state, because here in my county, both because we're a state-based exchange, both navigators and assisters are paid. In our county, they happen to be associated with our, the assisters are associated with our local health department, and the navigators are associated with a community action agency. So I think it can vary state to state, but there definitely were issues with training, because you mentioned the provision of culturally and linguistically appropriate services. So we went to several things here in Maryland and other states where, as part of the overall navigator and assister training, there was supposed to be training on cultural and linguistic competency as well as health literacy. Because the rollout was a bit rushed, some of those areas kind of didn't receive some of the attention that they should have. And has that been your experience as well, Andrea and Michael?
Yes, and those states that had the federally facilitated programs, there was just a small pot of money that had to be divided between all of the states who decided to go with that, to go that route. So like the state of New Jersey, not enough funds were available to really do diligence in paying a lot of the navigators, which is why they had to go to volunteers. So I think the volunteer programs, mostly in the states where you had federally facilitated exchanges.
Right, I see. Okay, so Brenda Snipes has a question. So, and I know you mentioned COBRA in the presentation, but what Brenda was asking is, how does the ACA work in relation to COBRA, and should employers continue to offer COBRA? So I'm going to kind of recap what I thought you said, and then feel free to pick up. But basically what you were saying is that usually after one leaves one's place of employment, you're allowed to continue your current insurance, except that you would pay the entire premium yourself out of pocket. But now, instead of having to do that, you would have the option now to purchase your insurance for yourself and or your family through the marketplace. So Brenda's asking then, do employers still need to continue their COBRA programs?
Well, that's a good question, and it's one that's being debated among a lot of employers now. And that would be employers of 20 employees, or I should say organizations of 20 employees or higher. Now, up until the end of this year, and we only have, I guess, a little over a month and a half, if there's a COBRA program in place and there's a possibility that you as an employee may be needing that service, it's a good idea to continue carrying that up until the point where your coverage kicks in through the marketplace, and you can obviously transition to the marketplace and eliminate having to pay that larger out-of-pocket cost that you have absorbed as a result of taking on that cost from your previous employer.
We can certainly expect that as we move forward with the rollout of the Affordable Care Act and people begin to understand more about it, and we get a look at what these premiums are and out-of-pocket costs, employers are every day reviewing their programs and determining whether they will keep them or push their people to one of the marketplaces. So it's changing every day.
Right. And actually, I thought that might be a good segue into a question about the affordability of one's health insurance, because oftentimes people think, well, I'm not uninsured. I have insurance through my employer, but it's not affordable. So it's my understanding that if your health insurance plan through your employer is not considered affordable, meaning it costs more than 9.5% of your income, that you also would have the option. Okay, so I was wondering if you could clarify that.
Yes, that's correct. You know, affordability is described as being below 9.5% of your income. So if it's 9.5% or higher, then you can abandon your employer-sponsored program and actually go and get insurance through the marketplace.
Now, Cherie, I think it's important to mention that even with the healthcare marketplace out there and the ability to buy insurance outside of the marketplace, with the expansion of Medicaid, there will be some people who still fall through the gap. There are some individuals who don't qualify for any of this and will not have insurance. We do still have that segment of the population.
Right. No, you're absolutely correct. And actually from the data I've seen, and again, those reports that are coming out daily and sometimes several times daily, is that in some of the states where you had the most uninsured people, those are some of the states that did not choose to opt into the Medicaid expansion. And so those are some examples of people who will not qualify for Medicaid. They can't afford private insurance to the marketplace, so they will indeed fall through those cracks. So that's an excellent point. Whereas in other states, I can give you again the example here in Maryland, we did opt into the Medicaid expansion, and we're interesting in that we are covering people up to 400% of the federal poverty line. So you could be a family of 4 with a household income of up to, I believe, $92,000 or $94,000, and you would be eligible for some combination of Medicaid as well as the advanced tax credits. So it completely varies state by state, which is why you really need to find out what your particular state is doing. So that's an excellent point, Andrea.
That's what I meant when I said education here is going to be so important, because if you're in a hospital and you have individuals who are working with consumers or patients, prospective patients coming in, they have got to know the various scenarios that can exist with any individual. You know, is this person one who didn't even qualify for insurance, period? Or is this person one who actually should have gone into the marketplace and gotten insurance? So that there's a huge mix of individuals and possibilities.
Right. I agree. Thank you. So along with Brenda's point about COBRA, she has a follow-up question. Is COBRA likely to fail the affordability test for the low-income people? So I'd add there, any one of us, I mean, if anyone has ever been in between jobs and you saw those premiums for COBRA, even if you had a nice salary beforehand, COBRA is outrageously expensive, even for those of us who are not low income. So to Brenda's point, do you think that COBRA would fail the affordability test?
Absolutely.
Yes, because it is.
You know, unless they make some changes, you know, I do think that the rates will be too high in COBRA.
Right. Agreed. Oh, good. So we continue having questions. This is great. We have a question from Masa Song, who is asking, I don't know if we can answer this, but it is an interesting point to make. Are we seeing an influx of people moving from states without Medicaid and Medicaid expansion? Yes. I personally haven't seen anything on that, but Andrea or Michael, have you heard anything?
People absolutely will look to move, and I think there are some stipulations being put in place regarding how long they have to be like a resident of that state or something like that. So I think that possibility certainly was thought of, and you know, states are having to determine what restrictions they're going to put in place for individuals doing that.
Okay, great, thank you. So a few more questions. What about, this is from Lisa Walker, what about deadlines? We have heard the deadlines have been extended. So it depends on what aspect of the Affordable Care Act we're talking about, because deadlines have been in under certain things. So Andrea and Michael, could either of you?
Michael, you want to address the difference with the small business or the business versus individual?
The question was about deadlines. Could you actually repeat it? I'm sorry.
Cherie, what is the question again?
Yes, let me repeat this. Sorry. The question is, What about deadlines? We have heard the deadlines have been extended. And it would have to be specific to something. So you mentioned, for example, Andrea, small business or large employers and different things like that. So would you like to address anything you're aware of?
Yes, I mean, larger businesses have been given reprieve for 2014, so their penalties won't come into effect until 2015. So that's one of the deadlines that's been pushed out. There have also been some discussions about whether they should push out the enrollment period, but that's still under discussion, and so they don't have a final ruling on that. And there are other deadlines related to other aspects for specific states that continue to be debated.
We expect that with the problems they've had on healthcare.gov that they likely will push out this enrollment date. Right now it's, what is it, Mike, March 15th?
March 31st.
March 31st.
March 31st, right. We expect that probably will be pushed out, especially if the government has not straightened out these problems as they anticipate by the end of this month. It's likely that will change.
Right. And along with that, too, I believe in order to have coverage as of January 1st, I believe you had to actually be enrolled by December 15th, because you can't enroll on December 31st and think, yay, on January 1st I have a card and coverage. So again, with those glitches, you wonder if there will be an extension. Now, the second half of Elisa's question was penalty deadlines, and I know we talked about them for employers, but I wonder if she's wondering if there will be an extension of the penalty deadlines for consumers because of the glitches. And again, there hasn't been a ruling yet, but we're all eagerly using it.
Right, right. And what happens, and I guess this is worth mentioning, once that deadline hits, if it's March 31st or if they extend it or whatever, no one can enroll in, through the healthcare exchanges until the next year, until the next enrollment period, unless they have an event which, allows them
Life event change.
Yeah, a life event change, like, having a child or something like that. They will not be allowed to enroll until the next enrollment period, which happens in October, I think, of the year.
Yes.
So they will miss that period, and a lot of people are not aware of that. If they haven't had insurance before, they don't know anything about these various enrollment periods that exist.
Right. And Andrea, along with that, we were having a discussion of, so initially the penalty of $95 or 1% of your income might seem pretty low, but it's the higher of the two. So people might say, oh, it's just $95, but if I make $30,000, that 1%, is kind of hefty. And over time that increases. And so you'll be paying a penalty, but you still will not have insurance.
That's
correct.
It's, again, helping to educate people of, would you rather pay a penalty or would you try to get insurance? And if you're at $30,000, you're likely eligible for some kind of tax credit.
That's right.
%. So regarding the 9.5%, which determines affordability, is it 9.5% of household income or the consumer income?
It's household income.
Household income, right. And very similar to when you're actually filing your taxes. If you itemize your deductions, it used to be 7.5% actually, but basically it was 7.5% of your household income. Now it's 9.5% for affordability. So, great. So I know we're coming to the end. Let me just quickly look through to see if we had any other questions that came through. And this has been great. This has been very helpful. So I'd like to ask a quick question of our attendees who are still remaining. Again, I thank you for your attention and for sticking with us for so long. But if you had the opportunity where you had a half hour or an hour to just be able to get your questions answered, like no presentation, just, my family situation is such, or my friend has X or Y, or my hospital is encountering whatever regarding the ACA. Is that something in which you would be interested in participating in, that you think others would be interested in participating in? So I see some hands raised. Okay, that's great. So again, I'm just looking through any last questions, but you will also be receiving an evaluation of the webinar. And if there are other aspects of the Affordable Care Act that you are interested in learning about, if you could mention that in your evaluation as well. So I'm just, again, quickly with the handful of minutes we have left, just scrolling through the questions to see if I've missed anything, because they were coming fast and furious for a while there. I think I have covered all of them. I'm just double checking here. Yep, we actually have. So that's great. So again, I would like to thank everyone for their time. I especially would like to thank Andrea and Michael Thompson for the expertise that they have shared with us and the knowledge. And I hope that this will give you enough information that you'll be able to go back to both your healthcare organizations or if you're a healthcare provider and be able to educate your own staff, make yourself aware, and that hopefully it will help this transition and this rollout run a little bit more smoothly. Andrea or Michael, do you have any closing words or anything, any last tidbits of wisdom you'd like to share with our participants?
I'd just like to say that one of the...
Go ahead, Michael.
I was just going to say that one of the other things that you'll certainly be noticing is that the narrowing of networks from the insurance carriers, and that also could potentially create some issues for some of the patients coming in who don't understand that your hospital may not be in network for them.
Oh, that's an excellent point. Thank you for raising that. Okay. And Andrea?
I really just want to emphasize educating and learning more about the Act and what's taken place and what's going to take place in future years, as well as learning health insurance, getting to know health insurance.
Great. Thank you.
Thanks,
so with
everybody.
That, again, thank you, everyone. Thank you for your time. Look forward to the emails you will receive with the webinar evaluation, as well as the links to the recording and the presentation slides. Have a great afternoon. Thank you.
Thank you.